Hey there, it's nighttime, but let's look at more past paper type questions.
Okay, let's look at question 1. So question 1 says, a healthy athlete has a PR interval of 240 milliseconds. Every P wave is followed by a QRS complex. So you can pause here, and then these are the options. You can try and get it. And once you unpause, we'll say the correct answer is C, first degree AV block. Now let's think about it. Why is it C? So the reason it's C is because a normal PR interval is between 120 and 200 milliseconds. So once it exceeds 200 milliseconds, you've got a delayed conduction. You've got delayed conduction through the AV node. So the important thing is that every atrial impulse still reaches the ventricles. So nothing is dropped. So this is simply delayed conduction. Not intermittent conduction, not complete block, just delayed conduction. That's exactly what defines first degree AV block. Now let's look at question 2. So question 2, a patient presents with palpitations. The ECG shows narrow QRS, irregular rhythm, rate 180, no visible P waves. So you can pause here and try to get the correct answer, and you'll see that the correct answer here is D. Now why is it the correct answer D? The correct answer is D here because whenever you see something like this, sudden onset palpitations, regular rhythm, narrow complexes, heart rate between 150 and 250, then you can always think about AV nodal re-entrant tachycardia. And the reason why is because why are there no P waves? Because the atria and ventricles are activated almost simultaneously. So the P wave is buried inside the QRS. And if this were atrial fibrillation, the rhythm would be irregular. If it were ventricular tachycardia, you'd expect broad complexes. Yeah, okay. Let's look at question 3. So for question 3, so positive lead 1 and positive QRS in AVF. What's the electrical axis? Now the answer here would be the answer here for question 3 would be B. So normal axis. So a quick exam trick would be that don't calculate angles unless you have to. Instead, remember 4 quadrants. So lead 1 positive, AVF positive equals normal axis. Now let's look at question 4. So question 4 says that which ECG finding suggests right bundle branch block. So and the correct answer here would be RSR pattern in V1. So this is a famous rabbit ears. And why is that? It's because it's the famous rabbit ears because the right ventricle depolarizes late. That delayed depolarization creates that second R wave. So a cool memory trick here would be RBBB, so rabbit ears right side. So rabbit ears appear in V1, and that's a cool trick. Okay, let's look at question 5. So question 5 says that convex. So to summarize question 5, convex ST elevation in leads 2, 3 and AVF. And the correct answer for this would be inferior ML or inferior M. Yeah, it would be inferior M1 or MI. And always memorize the STEMI territories. So inferior would be II, and AVF. Anterior would be V1 to V4. Lateral would be I, AVL, V5, and V6. Septal would be V1 to V2. And posterior would be ST depression in V1 to V3 with 2 R waves. And those territories those territory questions appear consistently in exams. Let's look at question 6. Which electrolyte causes tall peaked T waves? And the correct answer here would be hyperkalaemia. So think high potassium, high T waves. Eventually you'll also see widening QRS, flattened P waves, sine wave ECG. That's a medical emergency. So question 7. Question 7, completely irregular rhythm, no P waves, narrow complexes. The correct answer will be atrial fibrillation. And this is probably the easiest rhythm diagnosis. Whenever you hear irregular, your brain should instantly think about atrial fibrillation. Let's look at question 8. ECG evidence of LVH. Which criterion supports this? And the correct answer here would be R in V6 plus S in V1 greater than 35 millimeter. Let's look at question 9. So for question 9, progressive PR prolongation, then dropped QRS, and the correct answer, Mobitz type 1. Now let's look at question 10. What strongly suggests ventricular tachycardia instead of SVT with aberrancy? And the correct answer would be, in this case, AV dissociation. And the reason for this is the atria and ventricles are doing their own thing, and this is one of the strongest diagnostic clues for VT. Let's look at question 11. So pathological Q waves represent, and the correct answer is necrosis. And why is the correct answer necrosis? Because you can remember the progression of MI and ischemia, and then ST depression, so T wave inversion, and then injury, and then ST elevation, and then ST elevation necrosis and pathological Q waves, and this sequence is tested quite repeatedly. Let's look at question 12. So for question 12, short PR, delta wave, broad QRS, and then the answer here would be WPW syndrome. And the reason for this is the accessory pathway allows impulses to bypass the AV node, and that early ventricular activation produces the delta wave. So short PR, delta wave, WPW. Let's look at question 13. So for question 13, atrial flutter with 2 by 1 block, ventricular rate. So the answer here would be 150 beats per minute. An atrial flutter typically fires at around 300 beats per minute. So half conduct, half reach the ventricles, and 300 divided by 2 equals 150. So quick maths. Now let's look at question 14. So for question 14, broad QRS, negative V1, broad positive M-shaped V6, and the answer would be left bundle block branch. So compared to RBBB gives rabbit ears in V1, LBBB gives broad notched R waves in V6. Let's look at question 15. So for question 15, hallmark ECG feature of myocardial ischemia, and the answer here would be horizontal ST depression. So remember that ischemia equals ST depression, injury equals ST elevation, necrosis equals Q waves, and students can often mix this up, and that can cause a problem. Let's look at question 16. So ST elevation V1 to V4 and reciprocal depression in II, and AVF, and the answer here would be anterior STEMI, and it's most commonly due to LAD occlusion. So remember, LAD supplies the anterior wall. A blocked LAD is often called the window maker. Let's look at question 17. So for question 17, a patient develops the following rhythm: twisting QRS, prolonged QT, and then the correct answer would be, let's look at the options first, and the correct answer would be Trousseau's the pointes. And the reason for this is it's the French for twisting of the points, and it's always linked with prolonged QT. So think twisting, QT, and magnesium treatment. Let's look at question 18. So lead I positive, AVF negative, or lead 1 positive, depending on how you choose to look at it, and AVF negative, and the answer would be left axis deviation. So again, use the quadrant method. Don't waste time calculating degrees, and that should hopefully help. Let's look at question 19. So which abnormality prolongs the QT interval? And the answer here would be hypokalaemia. So remember, low potassium, long QT, flattened T waves, prominent U waves. Now let's look at question 20. So complete heart block. What is the hallmark finding? So the answer here would be AV dissociation. The atria beat independently, the ventricles beat independently, there is absolutely no communication between them, and that's heart block. Now let's look at, oh yeah, that was question 20. And now let's look at a quick summary that we can think about for the high steel tips from what we learned from today's past paper type questions. So the first degree AV block equals prolonged PR interval. Mobitz I or Mobitz I equals progressively longer PR intervals. Mobitz II or Mobitz II equals fixed PR with drop beats. And complete heart block equals AV association. Hyperkalaemia gives peak T waves, hypokalaemia gives U waves, and prolonged QT. AF is irregularly irregular. Flutter usually has a ventricular rate of around 150 with 2/1 conduction. AVNRT is irregular narrow complex tachycardia with hidden P waves. WPW equals short PR plus delta wave. Inferior STEMI affects II, and AVF. Anterior STEMI affects V1 to V4. RBBB gives rabbit ears in V1. LBBB gives broad notched R waves in V6. And ST depression means ischemia, ST elevation means injury, pathological Q waves means necrosis. If you can confidently explain every one of those concepts, then you'll be in very strong position for your cardio section of your exam. And hopefully that helped you, and I hope that you can use it to help others, because that's our purpose as medical students and hopefully one day doctors. And thank you for watching, and you can like this video if you like this video. Thank you. Bye.